Welcome to the Certificate Program in Nursing and Nutrition, or CPNN. Today we will cover the module entitled Guidelines on Newborn Resuscitation and Emergency Care. On completing this module, participants will be able to recognize a newborn who requires help to breathe, discuss the steps involved in effective neonatal resuscitation, understand the approach to initial feeding and establishing a peripheral or central venous line in infants. Let us begin by discussing the neonatal resuscitation process recommended by the American Heart Association. On delivery, some infants may not breathe and need extra help to do so. Factors that are associated with a probable need for breathing assistance can either develop before or during delivery and are shown on the screen. Approximately 10% of newborns require some assistance to begin breathing at birth. The sequel for neonatal resuscitation is illustrated on the screen. In subsequent slides, we will understand each step in detail. Upon delivery, some infants may require resuscitation. This can be identified by rapidly assessing the following: whether it is a full-term gestation, whether the infant is breathing or crying, whether the muscle tone is good. If the answer to all three is yes, the newly born infant may stay with the mother for routine care. If the answer to any one is no, the infant should be brought to a radiant warmer as additional interventions may be required. The first and foremost step in resuscitation is thermal protection. The infant is placed under a radiant warmer. The head can be covered with a cap. The infant may be wrapped with a clear food-grade plastic film if preterm. Thermal mattress and increasing the room temperature also help prevent hypothermia or dangerously low body temperature. Then the infant is positioned properly. It is recommended to position the infant on the back with the head slightly extended in a sniffing position. This position opens the airway and allows unrestricted air entry. However, hyperextension or flexion is avoided. Secretions that obstruct the airway are cleared if the infant has difficulty clearing his or her secretions, if there is meconium-stained fluid, or if initiation of positive pressure ventilation is anticipated. This is done with a bulb syringe or suction catheter, mouth before the nose. Next, the infant is placed on a towel and dried gently in order to reduce evaporation. For preterm infants less than 32 weeks gestation, drying is not necessary. They should be covered immediately in polyethylene plastic. Generally, these steps provide enough stimulation to initiate breathing among newborn infants. However, if no adequate respiration is observed, the infant's back, trunk, or extremities are rubbed gently. Infants should never be shaken. After the initial steps are completed, further decisions are based on the assessment of breathing and heart rate. This should take no more than an additional 30 seconds. If the infant does not have adequate spontaneous respirations and a heart rate of 100 beats per minute or higher within 1 minute of birth, positive pressure ventilation is initiated. On the other hand, if the infant is breathing and the heart rate is at least 100 beats per minute, but he or she appears persistently cyanotic, then his or her oxygen saturation is checked with the help of an oximeter. Supplemental oxygen is used when the oximeter reading remains below the target range for the infant's age. Free-flow oxygen can be offered by holding oxygen tubing close to the infant's mouth and nose. If the oxygen saturation cannot be maintained within the target range despite 100% oxygen or the infant has labored breathing, a trial of continuous positive airway pressure or positive pressure ventilation is provided. Positive pressure ventilation is considered if the oxygen saturation below the target range despite free-flow oxygen or continuous positive airway pressure. Ventilation of a newborn's lungs is the single most important and effective step in neonatal resuscitation. It can be done using a self-inflating bag, a flow-inflating bag, or a T-piece resuscitator. During ventilation, the head should be neutral or slightly extended, sniffing position. The mask of the resuscitation device is applied. An airtight seal between the rim of the mask and the face is essential for providing positive pressure ventilation with any resuscitation device. During positive pressure ventilation, the initial oxygen concentration for term and late preterm newborns greater than or equal to 35 weeks gestation is 21%. In preterm newborns less than 35 weeks of gestation, it may be reasonable to begin with 21% to 30% oxygen. The ventilation rate is 40 to 60 breaths per minute. To help maintain the correct rate, the following rhythm can be counted out loud. Breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. Squeeze the bag or occlude the T-piece cap during breathe and release while counting 2, 3. The most important indicator of successful positive pressure ventilation is increasing heart rate. For the first heart rate assessment, the infant's heart rate is checked after 15 seconds of positive pressure ventilation. Heart rate is increasing. If the infant's heart rate is increasing, positive pressure ventilation is continued, and second assessment of the infant's heart rate performed after another 15 seconds. Heart rate is not increasing. If the infant's heart rate is not increasing, the infant is checked for chest movement with the assisted breaths. If the chest is moving, positive pressure ventilation is continued and second assessment of the infant's heart rate performed after another 15 seconds of positive pressure ventilation that moves the chest. If the chest is not moving, then the ventilations are not inflating the lungs. Ventilation corrective steps must be performed until chest movement with ventilation is achieved. Positive pressure ventilation is continued, and second assessment of the infant's heart rate performed after another 30 seconds of positive pressure ventilation that moves the chest. Second heart rate assessment is performed after 30 seconds of ventilation that moves the chest. If the heart rate is at least 100 beats per minute, the rate and pressure of positive pressure ventilation is gradually reduced while observing for effective spontaneous respiration and stimulating the infant. Positive pressure ventilation may be discontinued when the heart rate is continuously greater than 100 beats per minute and the infant has sustained spontaneous breathing. After positive pressure ventilation is discontinued, use free flow oxygen or continuous positive airway pressure as necessary to maintain the oxygen saturation within the target range. If the heart rate is at least 60 beats per minute, but less than 100 beats per minute and not improving despite 30 seconds of positive pressure ventilation that moves the chest, ventilation technique is reassessed. Ventilation corrective steps are taken if necessary. The oxygen concentration is adjusted as indicated by pulse oximetry, and insertion of an alternative airway is considered. If the heart rate remains less than 60 beats per minute despite at least 30 seconds of positive pressure ventilation, ventilation technique is reassessed. Ventilation corrective steps are taken if necessary. The oxygen concentration is adjusted as indicated by pulse oximetry, and insertion of an alternative airway, endotracheal tube, or laryngeal mask is considered. If there is no improvement, increase the oxygen concentration to 100% and begin chest compressions. Note that if continuous positive airway pressure or positive pressure ventilation with a mask must be continued for more than several minutes, an oral gastric tube should be inserted to act as a vent for the gas in the stomach during the remainder of the resuscitation. Chest compressions are indicated if the infant's heart remains less than 60 beats per minute after at least 30 seconds of positive pressure ventilation that moves the chest. Further, at least 30 seconds of ventilation through a properly inserted endotracheal tube or laryngeal mask is also necessary. Chest compressions should not be initiated if chest movement with positive pressure ventilation has not been achieved. In order to provide chest compressions, both hands must encircle, thumbs on the lower third of the sternum, Fingers under the infant's back to provide support. Perform quick compressions to 1/3 of the chest depth to generate a palpable pulse. The goal is to deliver 90 compressions and 30 ventilations per minute. Ventilation and compression are coordinated by performing one breath every 3 compressions and counting the following aloud: 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. Compress the chest with each counted number: 1, 2, 3. Release the chest between each number and. Pause compressions and give a positive pressure breath when the compressor calls out breathe and. When chest compressions are started, increase the oxygen concentration to 100%. After 60 seconds of chest compressions and ventilation, compressions and ventilation, if necessary, are briefly stopped to check the heart rate. If the heart rate is 60 beats per minute or greater, compressions are discontinued and positive pressure ventilation resumed at 40 to 60 breaths per minute. If the heart rate is less than 60 beats per minute, the quality of ventilation and compressions is checked. If ventilation and compressions are being correctly administered, epinephrine administration is indicated. In case of a confirmed absence of heart rate after 10 minutes of resuscitation, it is reasonable to stop resuscitative efforts. However, the decision to continue or discontinue resuscitative efforts should be individualized. To summarize, neonatal resuscitation can be divided into 5 components. Initial assessment. Determine if the newborn can remain with the mother or should be moved to a radiant warmer for further evaluation. Airway. Perform the initial steps to establish an open airway and support spontaneous respiration. Breathing. Positive pressure ventilation is provided to assist breathing for infants with apnea or bradycardia. Other interventions, continuous positive airway pressure or oxygen, may be appropriate if the infant has labored breathing or low oxygen saturation. Circulation. If severe bradycardia persists despite assisted ventilation, circulation is supported by performing chest compressions coordinated with positive pressure ventilation. Drug. If severe bradycardia persists despite assisted ventilation and coordinated compressions, the drug epinephrine is administered as positive pressure ventilation and chest compressions continue. Now let us understand enteral feeding in newborn infants. When are enteral feeds started? They are ordered by a neonatologist when the infant displays the following elements of clinical stability: tolerates increased oxygen intake associated with feeding, lack of cardiovascular or respiratory instability that is sufficient to overcome gastrointestinal perfusion, abdominal exam showing stooling and presence of bowel sounds with no tenderness, no reddening, no blood in stools, no infection of the umbilical stump or indication for abdominal surgery. What type of feeds are given? The approach to choosing the appropriate feed is depicted on the slide. Initial milk should consist of colostrum if available. Fresh mother's milk is the preferred milk. Donor human milk or formula may also be considered. Based on the infant's gestational age and birth weight, fortified mother's or donor milk, term or preterm formula is chosen. Since nutrition is important for normal growth and development in infants, tube feeding is used for children who have inadequate or unsafe oral intake and a functioning gastrointestinal tract. The conditions that necessitate tube feedings are listed on the screen. Several options for enteral access are available, including orogastric, nasogastric, nasointestinal, gastrostomy, jejunostomy, and so on. Access is chosen based on several factors, including the gestational age of the infant and duration of feeding, short or long term. Lastly, there are several types of feeds for infants below 1 year of age. Human milk is the preferred nutrition source for virtually all infants when mother's milk and or donor milk is available. Other feeds, such as standard infant formula, preterm formula, soy-based or hydrolyzed formula, are useful for infants with certain medical conditions. Finally, we will gain insights into the basics of peripheral and central lines. A peripheral intravenous line is required if the enteral, transmucosal, Intramuscular or inhalation routes do not suffice in meeting the infant's fluids and/or medication requirements. The easiest sites to place a peripheral intravenous line is the dorsum of the hands and feet, the triangular cavity of the elbow, and for infants less than 1 year of age, the scalp. The procedure to insert a peripheral intravenous line is as follows. Wash hands and wear gloves. Clean the chosen site of insertion with a surgical prep solution. Apply a tourniquet proximal to the site. For scalp, use a rubber band. Locate a straight segment of the vein and insert the catheter at 10 to 20 degree angle to the skin. Once there is flash of blood in the catheter hub, lower the cannula towards the skin and advance 1 to 2 millimeter. Finally, advance the catheter over the needle into the vein. Draw blood if needed. Remove the tourniquet and connect the intravenous line or prime extension tubing and flush. Secure the catheter and intravenous line with tape. Stabilize the limb with an arm or leg board. Avoid opaque dressings. Care of the cannula. The overlying skin must be kept clean and dry. The cannula should be flushed and filled with normal saline immediately after the initial insertion and after each injection. Certain acute and chronically ill infants may require a central venous catheter for infusion of intravenous medication, drawing blood, hemodynamic monitoring, infusion of intravenous fluids, chemotherapy, and parenteral nutrition, among others. Let us gain some insight into central venous catheters. A central venous catheter is an indwelling catheter that inserted by a surgeon. The tip of the catheter is inserted under the skin, and the tube is tunneled to the superior vena cava. This provides stable venous access, either short or long term, for both acute and chronically ill patients. Pediatric central lines include external catheters, totally implanted catheters, and peripherally inserted central catheters. The line is chosen based on the child's age, weight, time period of requirement, and purpose of the catheter. Upon placement of a central venous catheter, daily care is essential. This includes practicing hand hygiene prior to central venous catheter care, ensuring sanitization of the access port with chlorhexidine or alcohol, povidone iodine, or iodophors before and after each use. Trying to minimize the number of times the central venous catheter is accessed. Regularly replacing intravenous tubing and caps based on the hospital's protocol. Evaluating blood return from the central venous catheter every 24 hours. Maintaining clean, dry, and intact central venous catheter dressings. Preventing infections by practicing daily hygiene and linen change. In summary, on delivery, some infants may not breathe and need extra help to do so. Initial assessment, airway management, breathing support or ventilation, improved circulation or chest compressions, and drug administration are the key steps of neonatal resuscitation. An infant must be clinically stable to initiate feeds. Fresh mother's milk is the preferred milk. Donor human milk or formula may also be considered. Tube feeding is used for children who have inadequate or unsafe oral intake and a functioning gastrointestinal tract. Peripheral intravenous line is required when other routes do not suffice in meeting the infant's fluids and/or medication requirements. Certain acute or chronically ill infants may require central venous catheter.